Take it away.
Thank you so much. Very humble and honored to be here to be presenting about ICE in front of Dr. Saric, who, if you don't know, is the expert in imaging out of Mount Sinai. I've done several cases, proctored cases with him, and does an amazing job. So, ICE utilization. Let's start with the case. This is an 85-year-old with chronic AF, and I was told the videos are going to work. Okay, so no riots. A chronic AF, severe anemia, unable to tolerate anticoagulation, left atrial appendage occlusion. So this is what we're dealing with: an enlarged left atrium, and almost really thick smoke in the left atrial appendage, right? And almost a thrombus at the distal end. So here's the question: what we could do over here in this case. And we decided we need to understand this a little bit better and put ICE in the left atrium and understand if this goes away or not. Another way to do this was to use isoprel in such cases as well, where some of this goes away. But we get much more confidence in amulet in these cases like this because your implant is much more proximal. So you're not disrupting some of the stuff, and you can close some of this. So this patient really needed it, so we went with it. Okay. So there you can see our transeptal. So this is using ICE. Now you have, this is a 3D ICE catheter. Remember the 3D ICE, this is a Siemens. Their 2D pictures are not the greatest, okay, but it can function. This is an example of how we use ICE to do transeptal. Of course, the lower you can go, the inferior you can go, the better it is. This is the ICE sitting in the left atrium, and this is the basic view where the catheter is. The advantage of 3D is rather than all the views that Devi taught us about putting it by having an aortic valve, mitral valve in view, and then putting it under mitral valve, you can put it in one area and create what is called multiplanar reconstruction. So you can swipe it around, and it'll give you a 3D image, and you can see there's a nice 3D image on there, and we don't see any distal clot. So we were pretty happy. Of course, the patient is fully anticoagulated by now. We give anticoagulation before heparin before transeptal puncture. Okay, so some of the measurements that we do using the MPR technique, you can see, you can measure the antrum out here. I have to tell you that there was a TE present, but we have blinded ourselves to the TE pictures, so we're not looking at it. We're just using 3D intracardiac echo. And these are some of the examples of measurements that we got, which have been taught much more extensively before, so I'll jump on to the next one. This is how we deploy. So pre-deployment, you can see the sheet. Now my ICE catheter in this case now is parked by the mitral valves. It's kind of the 135 view. You can see the sheet beautifully. You can see the circumflex nicely. This is the ball formation, as you can see. There's the ball formation, and past the circ. This is where I'm going to go into a triangle mode soon. So this is one deployment, and I chose this specific case because I wasn't happy with this deployment. You can see that part of the device is actually sticking out. The lower part is there, so I decided that I think I have a little bit more room to go in. And of course, we were a little nervous about going too deep in this case because of the distal potential thrombus. So we recaptured this and went a little bit distal this time, created this, and a little bit more forward pressure in the triangle mode, and then did this. So it seems like the whole device now is inside, and you can see that this is why I think a dual seal technology is very important, and I'm glad those questions come up because you really need to start thinking the left side of the brain here. Now you have two options. You know that there is a gap in there on the top, right, towards the pulmonary width side. So you have two options. You take this out, put a bigger device in with a risk of stretching this in an 87-year-old, or you use your disc to cover the rest of it. So I want you guys to be the judge of that, how we utilize the disc in this case. People should be pretty sure and confident that this lobe is pretty anchored on one of the edges at least. So this is how where the disc was deployed. You can see how that hole gets covered. This is still 3D ICE pictures, and you can see how it sits beautifully to cover that remaining of that area which was uncovered. You can see the 3D pictures here as well. And this is my tuck test where I'm pulling it back a little bit, trying to orient my disc even more to try to have it sit on top of that ridge. And these are the final pictures as it sits, and then you can do your color. And this is the release as you see. You can see that there is no leak whatsoever in this case, and device has been released. Final pictures we used using the 3D as well, where you can see, again, nice figure of 8 over there, and post-deployment evaluation. These are the fluoroscopic pictures, just to correlate you with the same case. This is the ball-shaped angiogram that you can see. Of course, we minimize the use of contrast in this case because of the potential clot. This is the device orientation. This is the final tuck test, as you can see. And this is the eventual. There's no contrast going in or out of this. And the device looked quite stable on this. And this is the final TEE pictures that we got at the end of the case, just to confirm that everything looked good. So one of the examples of how we can utilize 3D ICE in clinical practice, and I think over the next year or 2 years, you're going to see much more of it. So some of the quick things, vascular access for ICE-guided left atrial. This is a 2D catheter, but it's something similar. We do dual venous access, typically same side. This one is showing figure of 8, but we use per-close and pre-close techniques for potentially early ambulation, same-day discharge. This is an example of what I was telling you, parking a wire in the pulmonary vein and getting very comfortable of advancing your ICE catheter over the wire. It does take a little bit of learning skill, but once you get it, you can probably do it quite quickly. This is the imaging part of it, where you can see, and I wanted to point one thing out here, which is the inferior nature of the stick. You see how inferior this is? When you do that, your life becomes so much easier. So this is see how the sheet sits so low? So if you take a really inferior stick, it's so much easier to access all this as compared to when you go here or high here. So this is another example of ICE imaging this is a 2D ICE actually. You can see the ball out here. This is a deployment and the disc. This transeptal puncture we went through. So yeah, let me go through this real quick, use of 3D ICE in the LA. So there are 3 basic views that she went through, Devi went through real quick. I'll just go over them again. One is where you park the catheter by the right superior pulmonary vein or middle of the left atrium, and you can see the mitral valve first. So that's one view. That's kind of equivalent to your 45 view. And then you want to counter it a little bit to get the aortic valve to open it up a little bit, okay? So these 2 views. This, and then you park your catheter deflected down by the mitral valve, and you're looking at it up. That's equivalent to your 135. And when you have 3D ICE, you really don't need to do too many maneuvers like this. You can just get a couple pictures and use the MPR to create it, which makes life much easier for you. This is some of the examples of starting from the mitral view and then going towards this. And using MPR to obtain the coronal view, which is the blue plane. And another example where you can actually create the orifice and measure your measurements. So do we have any data? So this is some of the original data that was published several years ago, compared data on use of intracardiac and transesophageal echo for left atrial appendage occlusion. A really neatly done study. If you guys are not familiar with this, I would recommend that you take a look. Aim of this analysis is to compare patient procedural characteristics using results that have been independently analyzed. The 1-year results from patient in the prospective global amulet observational study. The LA closure was assessed by an echo core lab, okay, and 1088 patients enrolled with 1078 successfully, 80.1% patient discharge or antiplatelet therapy. So this is the implant success. You can see ICE is 99%. The general anesthesia used was only 7%, so that's important. The contrast used is a little bit higher, so those are important points. And then if you look at the residual flow, it's pretty comparable and maybe a little better in the ICE. So summary and conclusions, large prospective global study, higher risk both ischemic stroke and major bleeding. LAAO guided by ICE is a valid alternative. allows implant with local anesthesia, results in comparable clinical event rates, and there was significantly higher contrast volume as expected. So what to expect, not dissimilar from AF ablation. We started with pre-procedure CTs in AF. We shied away from them. We now rely heavily on peri-procedure imaging, using intracardiac echo and maybe 3D eyes in the future. The improvement has to happen in peri-procedure imaging for us to do this LAAO. And this is where the field needs to go personally, using rotational angiography or improved 2D and 4D images and better delivery tools. Thank you very much.
Thank you very much. I'm Matthew Price, interventional cardiology at Scripps Clinic, La Jolla. So I've been asked to evaluate the pros and cons of CT pre-planning. And I've called this presentation Confessions of a Former TEE Junkie. So I just have 10 minutes. This is going to be a very practical discussion, not very heavy on data. Just how I've adopted CT in my practice and the rationale for doing so. Before I start, I thought I'd query the audience about people's practices. Now, I'm very much against the concept of routine practice, so I'm going to ask you, for the majority of the time, the average patient, how many of you are just doing a TE on the table, no pre-procedure imaging whatsoever? So I'd say about, well, I don't know how many of you are implanters versus Abbott, but I would say maybe 30%. All right, so how many people are doing upfront CT before the procedure and then some sort of imaging? It's about the same number. And how many people are getting a TE before the procedure and then do the procedure the day of? So pre-T. All right, good. So I'd say about 20%. So a really good spectrum. So why I loved TE pre-planning and hated CT. So this is bringing patients in to do a TE first. Now, I'm echo boarded. I say that, it expired probably around a decade ago, but I was echo boarded. Let's not talk about my interventional cardiology boards, and MOC, that's a whole nother thing. I have to go do that after this. All right, so I am a cardiologist. I'm not a radiologist, all right? And I'm getting gray now. I was not trained to read CT, and I'm not COCATS 3, CT, whatever it is. So the whole concept of getting a CT just killed me. And just having to analyze it on the software platforms by GE, or we have GE for our CTs. I did think as a cardiologist it was important to gain additional information before the procedure, such as if they had MR. These patients with chronic AF, a lot of them have AFMR or other reasons why they have mitral regurgitation. Presence of a large PFO. Sometimes you find surprises. I always kind of like to get to know the patient, right? An important practical thing was to create skin in the game for my partners. So upfront TEs, my partners were doing those, right? And then they said, oh, Matt asked me to do this TE because they're going to do a LAAO. Oh, it's LAAO. He's doing a lot of them. This must be an acceptable procedure. So early on in my career for doing LAAO, I think it was really important to get my group involved in LAAO. And the same is true for the partners who did it afterwards as well. So TE was in the procedure itself, excuse me. I'd also say the randomized trials of LAAO, whether it be the Amulet IDE or the prior Watchman trials, all used TE pre-planning. So CT, it is not the data of outcomes with CT as there is, the robustness of the data is not there compared to TEE. But there are downsides for sure. And the more you do, the more that you see. It is an additional invasive procedure. I think a lot of patients, there's always a little bit of attrition in your patients, right? The more things that are needed, and you tell the patient, well, I got to put this thing down your throat before we do the procedure. It's kind of like, have you ever had an endoscopy? No, they haven't. They often will not want to come back to do that procedure. Certainly our patients are older, and often there can be complications. I mean, if you do a lot of them, and you guys know this from a lot of EPs here doing a lot of AF ablations, you can get esophageal perforations from the TEE. I mean, it happens. You can have cricothyroid ridges, and you get called, oh, Matt, we couldn't put the probe down, and then it's a whole disaster. You have to admit the patient, maybe they aspirated, and so forth. And really, I think the actual thing that really caused our switch was COVID, where the T docs didn't want to do Ts, And we actually have anesthesiologists where we do TEs. They give propofol, and the anesthesiologists didn't want to do TEs. So I had to sort of change my thinking cap a bit. And that changed it. In combination, we'll talk about this with 3D ICE. And I'm going to talk a little bit about what I do now for pre-planning and what I think is the vision for the future for LAO in general and for all of us here in this room. So what are the goals of pre-planning? One, to exclude LAA thrombus. B, to assess anatomical suitability to determine device size. As Thaby beautifully illustrated, to define the LAA orientation and optimal transeptal puncture location. To define adjacent structures of the mitral valve or the pulmonary artery, to identify the optimal fluoroscopic view. I think this is less important because you can often just figure it out by angiography. And your options really are CT pre, TE pre, or TE on the table. So there is data. This is like only the one data slide I think I have. There's been plenty of studies comparing sizes or sizing of the LAA with CT compared to TEE. And no matter how you slice it, pun intended, you find with CT that you get about a 2 or 3 millimeter larger diameter than with TE, which makes sense. A, the patients are generally not MPO for half the day, and B, you get better resolution with CT. So I think this is an important thing. So and CT gives you what's there. So I think this quickly, what is the future for pre-planning? This is just one of my cases. I think maybe you might have shown one of these. This is a FEOPS where and there'll be other companies where you use artificial intelligence to computationally model the interaction of the device with the LAA and what it's going to look like with an optimal position. So going into the procedure, you know everything. And Chrysalis eloquently spoke about flow and having that device open maybe before you even get the transeptal puncture is moving things along. We'll talk more about that. And we know that CT simulation pre-planning versus standard pre-planning, mostly CT but some TE, reduces multiple deployments of devices with the amulet, improves closure, improves implantation, improves number of device repositionings, and improves the use of radiation and contrast media. So certainly CT pre-planning, and I think in the future, plus computational modeling is really important. So if you walk through these goals, you can say, all right, well, let's compare TE with CT. And a lot of this is opinion, but it's the right opinion. So I do think that TE excludes thrombus better than CT. Because you get delayed imaging, right? And they'll say, well, we suspect thrombus. And you get a CT, and you get a TE just to check. We're going to talk about post assessment later, but whenever they say there's thrombus on the device by CT, I'm always suspect. Although they can do the Housfield units and all of that. So I think T wins in terms of thrombus. Assessing anatomic suitability, I think CT wins hands down. You can slice all 360 degrees. You can do different parts where your landing zone might be. You can check your ostial size. So certainly it's better. That in turn guides your device size. I think you certainly, I give talks about how to define the orientation of transeptal puncture based on TE, so it can be done. But CT reconstructions, you just go to an areocaudal equivalent on your CT reconstruction, and you know whether you have to be inferior or mid on your stick. And you can define the adjacent structures like mitral valve and pulmonary artery better on CT, but obviously the function not as much. And that's obviously better by CT. So, but stepping back, like how can pre-planning really help us? And there's now and then there's 5 or 10 years from now, and then some of us are doing this now, is what we want when we do LAO is no complications. It's a prophylactic procedure, all right? And they're not making anybody feel better when they leave your lab. So 0 complications, rapid throughput. The day when Catalyst shows non-inferiority and hopefully superiority for bleeding, your labs will be busy, okay? And you can't do 3 procedures a day in one room with an anesthesiologist. You're gonna need rapid throughput, and then you want your patients to be happy when they leave. And you want them to tell their friends about what a great experience they had in your hospital. So what does that mean we need to do? We need to minimize decision-making during the procedure. No hemming and hawing, oh, maybe we should do a 28 or a 31 or 26 or what have you. You want to minimize device repositioning, minimize device size changes. You want to open up the device maybe as you get access. And I really think we're going to need to move to moderate sedation. Just for me, like any other IC, interventional cardiology procedure, I know you're in the EP lab, you're more used to using an anesthesiologist, but if you can knock out 8 cases in a day, or 10 cases in a day in 2 rooms versus 3 or 4 in 1 room, that's going to be really helping your cath labs. And I think the future for that is eliminating general anesthesia and definitely using CT pre-planning and 3D ICE. And now we're not there yet in terms of availability of 3D ICE, and certainly I did my first ambulatory cases with TE before I moved to ICE, but I think projecting now 4 or 5 years from now, I hear there's a lot of high volume implanters here, I think our goals as a community for LAAO should be this in the coming years. So more data just briefly about CTO pre-planning. So there is a sub-study of the Swiss Atrial trial, which Lars Sondergaard mentioned earlier, where they did this technique where they blinded the first cohort of patients, or they blinded the operators of the first cohort of patients of the pre-procedural CT. And the procedures were guided by TE. So that's really no CT pre-planning. And then the second cohort, they allowed the operators to see the CT that was done beforehand. And they found some very, I think, fascinating and things that should change our practice. Number one, patients who had their unblinded CT were more likely to have moderate sedation. They were more likely to get less contrast, and the radiation dose was lower. CT pre-planning versus no CT pre-planning. What about procedural outcomes? Short-term procedural success was better in the CT pre-planning group due to less PDL, less major procedure-related complications, and less major bleeding. And the long-term procedural success was better as well. So this is really comparing CT up front versus plus TE on the table versus TE on the table. And a clear advantage with CT pre-planning. So you can say, well, maybe there were confounders, so they did a multivariate analysis, and you see that being unblinded to the CCTA was an independent predictor of short-term and long-term procedural success. Okay, so again, just adding to the robustness of the data. So I only have a few minutes, I'll just show some cases. So this is a CT reconstruction of a challenging appendage, a pretty severely vertical anterior chicken wing. So this is, if you look at the little numbers down there, this is an RAO caudal projection. And I like to think about the clock face, and this appendage is at 12 o'clock. This means that I'm going to need a really, really inferior stick and a lot of counterclockwise rotation on my non-deflectable sheath. I see that the average size is 14, the max is a 16. We decided to open up and prep a 16 millimeter device right off the bat after we got access. And I can tell you, as someone who does a lot of TE, that this is going to be very hard to see on TE. That if you did a TE, you would say, well, I've had cases where if you do a pre-op CT, pre-op TE, the TE doc will say, well, I don't even see an appendage here. I think the patient has like a micro appendage. That's because it's so superior, you don't see it on any of your angles. So here, CT sizing is going to be better. So this is actually the intraprocedural TE. This is a TE guided procedure. You see the 90 and the 135. Like really hard to make heads or tails of what's going on. So now this was a challenging procedure. This is not like your, Chris would say this is not like your standard deployment, but to maintain the counterclock on the sheath, I had to go to ball at the very os of a very shallow appendage, okay? So I unsheathed the ball being very careful here. So we've deployed the lobe, deployed the disc, and a beautiful final release. This was a very fast case, and everything was open before I even did the transeptal puncture. Okay, so let's go to the ultimate case flow. Something I mentioned, what I foresee is the present in many labs. It should be all of our future. So, and this is how I do amulets now. So CT planning 1 to 2 weeks before the procedure to exclude LAA thrombus. I think that getting an RVOT view can be challenging in older patients with large atria or LV dysfunction and rotation of the heart. And a lot of those are, I see a lot of older patients with multiple comorbidities. So I like to do a CT and then keep OAC on until I have them stop a couple of doses, so it's not therapeutic, but have a very short span of not being covered, so the likelihood of thrombus is very low. Procedures with moderate sedation, 3D ICE guided, we'll talk about that. Prep the device while getting access. I don't size the LA at the time of the procedure. I've done the CT. How's it going to change? If anything, it's just going to be a little bit smaller, but maybe that's actually incorrect when the patient is volume loaded. I then implant the device, and then I evaluate the position by 3D ICE and fluoro and angio, or the lobe, and then the disc, right? And then I release the device. So here's an example. So this is the baseline view of this appendage. This is FEOPS pre-planning. And so this is the baseline view. This is an RAO caudal, so up and to the right. So this would be sort of a standard inferior mid, inferior posterior stick. This is what it's going to look like. Another tough case. Nothing looked perfect, but the 25 device I thought was the best looking device. So I'm planning to go up with a 25. So you can do everything with 3D ICE and 2D ICE, but it takes a little more work than you can with TEE. So this is, you always check for a baseline effusion check. So this is a nice little, you can get a nice 4-chamber from the right side on ICE. You can do a far field LA clearance, or you can do the RVOT. So I tend to, I'm a man of efficiencies. I just take an 8.0 balloon and balloon the septum. I don't dilate with the delivery sheath because it recoils. And these will close up. I mean, we do MitraClips all the time, and that's a big sheath. So I take my 8.0 balloon, and that allows me within seconds to get across my ICE into the LAA. So this is my injection. It looks just like it did on the CT, which is always nice. And I'll show you the ICE images in a second. I showed this, I was so proud of myself. This is my going to lobe. Look at this, is like the most just gentle transition from triangle to lobe I ever did. Look at that. I mean, my clinical specialist said, "Oh, Dr. Price, that was very nice." But he says that every time because he butters me up, but it's okay. So I take my picture here. It didn't play, but you can see, okay, this is what it looks like by angiography. Now, this is the 3D ICE. I only showed one image. We only saved one image. It's not the best image because you can get what I'm doing, if you look at my ICE probe here, and the green, I believe, is the pointer, is whatever position gets the plane, the imaging plane, straight down the axis of the LAA is where you want to be. And then you just dial in your angles just like a TEE. You can do all 4 quadrants. You're in free space, so you can orient yourself to TEE angles if you want to. And here you see, nicely 2/3 past the circumflex. This view, the resolution isn't great, and the copy of the image isn't great. But here is, the lobe is down here, and the circumflex is up here. It's a beautiful implant of the lobe, and the other quadrants showed the same thing. And this is a final check after deployment of the disc. And you see here, again, I've planted it right up the disc axis. And this is just one, these are 2 of the quadrants where you have, again, your lobe looks great, your disc looks good. And this is actually the final result after release. And this is the pre-planning, which looks exactly the same, I would argue. All right, so there are downsides. 2 more slides, and I'll move on. I'm taking longer than I'm supposed to. So there is, listen, you got to get a CT to do CT. And with the, I don't know, we have 1 tech now at Scripps. I don't know how that's possible, all right, because everyone decided to harvest bees, I guess, after the pandemic now. There are apiaries now. And so we're looking for people, so there's limitation of slots. So you need scanner space. Patients have to drive back to get a CT scan. If they have renal insufficiency, you're not going to, I mean, if the creatinine is more than 2, I'm doing TE planning. Okay, so clearly if there's other reasons to get a TE, I'm doing TE planning. It does require post-processing, and I hate this. I'm sorry, I don't have time to do this. I use prepackaged things like FEOPS. I would tell you that if you're beginning your trek on CT, to speak with your Abbott team, provide them the CTs, and they'll help you with analyses. So I think that doing the CT analysis should not be the rate-limiting step for you to adopt CT in your practice. And I think there is one anatomical limitation with deep pectinates, that CT may not pick those up, and you may find that your appendage is more shallow in reality than it actually is. So that's really the main thing. So with that, thank you for your attention.
Thank you very much. So now we're going to go to the last presentation of this session. And let me tell you who I am not. I'm not an implanter. I think I'm the only professional imager on the panel. So I'll provide you this imaging perspective. I almost became EP fellow. When I was in the year that we were applying, there were four applicants, there were 3 slots, and I got short a stick, and I ended up in the imaging, but somehow came back to spend most of my time in the EP lab. So I'll talk about the defining post-procedure success with TE and CT. There'll be some overlap with the other presentations, but I'll provide you again the imager's perspective of this. But again, that the true success for all of these procedures is the triad of an implanter, imager, and the representative. So if you have just really the constant coordination between these 3 elements. So now I'll just look at where the imager follows. We're going to talk about the post-procedure. But I'll just, if you look at clearly we play a role in pre-procedure imaging, intra-procedural imaging, and post-procedural imaging. And then we have already discussed that the current practice is typically TE-driven, meaning that the transesophageal echocardiography pre, intra, and post-procedurally is probably the primary imaging modality nationwide, with some part of CT imaging. In my institution, we do not require pre-procedural CT imaging. However, that doesn't mean that we do not use CT imaging pre-procedurally, because, as you know, many of the same patients who undergo left atrial appendage occlusion are also the patients who might have had the prior atrial fibrillation ablation and for which they then had the CT. So then we can do this free CT that we can repurpose for pre-procedural planning for left atrial appendage. And the other is, as already noted, is ICE-driven, in which a TE is being replaced by ICE. And then, as you also heard, that it's not just merely a change of one imaging modality to the other, but the swap from a general anesthesia required for TE to a moderate sedation driven by ICE. But I think in that scenario, then a pre-procedural CT is a must because of the certain limitation of current 3D ICE technology. So I'll just show you, we have talked a lot about the ICE, and from the imaging perspective, I'll show you the 3 major ICE catheter on the market that you might be familiar, but I'll tell you the imaging perspective. So you're very familiar with the 2D ICE, and you have seen it many a times. You do it every day, but I just have that this is only 64 side-looking phased arrays, 64 imaging elements, because it has to fit on a very small, it has only one 90-sector image, and the frequency is 5 to 10 megahertz. And as you know, it's already, you do this every day for transeptal puncture. That's example. So next level for ICE imaging would be 3D ICE from Siemens that Usman showed. This, and this is a catheter with more pins, and this was doing ASD occlusion, but now you can see that it's a much longer. But the way it has, as opposed to other, it was a 64 imaging elements, this has a 4 times as many. This is 256 imaging elements, but it's not a phase array. It actually does a spiral rotation. That's how it acquires imaging. And because of this spiral orientation, it'll provide you with the 90 by 50 sector. As opposed to 3D, you have 90 by 90. So it's a TE provides you a true rectangular rectangular prism, as opposed to this will probably elongated rectangular prism. And these are the images. You will see that it's really, there is one sector is a 90-degree sector, and the other is a 50-degree sector. And then, for instance, this is an Amplatzer ASD occluder, again 90-degree, but the other is a 50-degree. So it's a cut the image a little bit. So you have to play much more with this in order to put the device into the, and then you can have unfast view, and we have right side, left side of the device, and then a 3D. And essentially, if you really do it correctly, you can even capture the whole device. As opposed to the newest generation of ICE imagers, ICE imaging equipment, this is, for instance, from Philips, there are 840 imaging elements. So this is, we're talking about 3 times as many what you do with the Siemens ICE. But, and this is probably not appreciated, this is a very different array. You see, it's 840 imaging elements, but it's a 56 by 15. So it's a very elongated rectangle, and that has a profound impact on imaging by ICE. So essentially, it's a true phase array. You'll have 90, but you will see why this phase array, the rectangularity of it, provides the problem. And again, if you see this, so this is the actual crystal, 56 by 15 elements. And how is that important? So essentially, look at the TE. It's a 50 by 50 imaging elements, giving you 2,500 imaging elements. As opposed to 3D ICE, because of this 0 by 56, you have 840. But now, if you pay attention to, for instance, angle change, it's a very different between 3D ICE and TE. You see, on 3D ICE, it's a vertical. So I see the 0 degrees is like in a different orientation. This is 0 degree on a TE, and this is 0 degree on 3D ICE. And then, therefore, if you actually, the imaging is minus 45, 0 and 45, which is equivalent to 45, 90, and 135 imaging. So therefore, if you scan it at the low angle, so at the 90-degree angle, that is virtually no imaging elements to image. And that's why it's really important to take this into account when imaging. Okay? Are we enjoying? Is it useful? Okay. So now we are going to do what I'm supposed to be talking. Okay, so we're going to look at the post-procedural imaging. So after, the device is placed, patient came 2 to 3 months later, and now we have to evaluate post-procedural imaging. But then here I'll quote one of our great writers, Maya Angelou, who said, you can't really know where you're going until you know where you have been. So essentially, if you really know to evaluate post-procedurally, you actually have to review what was done intra-procedurally. And this our understanding. So I'll just touch a little bit of intra-procedurally that emphasize some points that you already learned from this. And it is key to imaging. You see, whether you do ICE or TE, but many of the TEs is still being intra-procedurally, that you do imaging at standard imaging angles. Yes, you can go anywhere from 0 to 180, but it's really, if you want to compare procedure to procedure, imager to imager, we should use for left atrial appendage canonical views. Okay? So these are the 4 angles, 45 degrees apart. Those are really 4 angles, and I would encourage everybody to do that. And if you ever wondered who came up with this, it was from the initial trial of the competing device, Pam Douglas from Duke University. So these are 0, 90, 45, 135. I like to put them in this orientation because that makes you think immediately of biplane imaging. So, and then this is baseline T images. This is amulet measurements that are different than the Watchman. It is already emphasized for angles 45 degrees apart, but you also see that there is a landing zone diameter, and then there is a landing zone diameter is where essentially, as you know, where the sizing is, and then the anatomic orifice, and the distance between the two of them is 10 to 12 millimeters, and then finally is the total depth of the diameter. And I see that the orientation of this depth is perpendicular to the landing zone diameter, and it's not coaxial with the long axis of the left atrial appendage. And that not only that has an impact on the choice of device, but also impacts the transeptal puncture. Because you see that in a Watchman device, you say low and posterior, because you're trying to align yourself with the long axis of the left atrial appendage. But here with this device, it's often low and mid in order to actually make yourself coaxial with or be perpendicular to the landing zone diameter. And then I mentioned to you that we can actually repurpose CTs that were done for different reasons, like pre-AF pulmonary vein isolation and ablation. And this is the image from a CT using 3 Mensio. And I really have to give credit to my dear colleague, Dr. Alan Wainrip, who is an exceptional imager, who taught me how to do this. And actually from this, you can generate sort of pseudo-TE images from CT images. And the reason why I do that, essentially, if you already have one set of images and in your mind, which is 0, 45, 90, and 135, if you then recreate this from CT, then we are then speaking the same language. So a TE person and a CT person and fluoroscopists are talking the same language. And then again, as was pointed out, these measurements are about 1 to 2 millimeters larger than on a transesophageal echocardiography. So, and I think I find this useful because it's really, we are speaking the same language. And then I showed you these are 4 measurements that are 4 dedicated measurements pre-procedural for amulet. But often when I talk to my colleagues and are younger, when I try to sort of introduce them to the field, they are very lost because of the abstract nature of those 4 measurements. But I'm just trying to now superimpose those measurements onto the already installed device. So this is essentially a landing zone diameter. That's what we measured in order to fit the lobe with appropriate compression. And then this is the distance, lobe to distance, that's the 10 to 12 millimeters. And that measure, and then that's the first measurement, orifice, essentially relationship to the disc size, and finally total depth. Essentially, it's a sort of useful measurements, but it's actually, I would say that the lobe height is more important. That's depending on the size, that essentially the total depth has enough to accommodate the lobe height. And then, and this essentially, we'll go back to the Watchman side. You see that I just want to emphasize that how their depth is actually coaxial with the long axis of the left atrial appendage, rather perpendicular to the landing zone diameter. Okay, and then if you go to, this is my perspective on CT sizing, there are different ways of that. I showed you that the 3 Mensio recreating T-like images. But even with the simpler CT technique, even just the regular in-house CT imaging, you can actually recreate at least 2 most important views. And if the 2 most important TE views are 45 and 135. So therefore, and essentially 45 is also equivalent to areocranial, and 135 is equivalent to areocaudal view. And then with manipulation of a CT image, you can actually get exactly those and the measure whether for a Watchman device or amulet. But the advantage of all of that, you can actually, because the CT is intrinsically 3D technique, you can get the shape of the left atrial appendage. But this is sort of a lateral view, all of this, but we can do better. And I just want to show you that sort of in your head, areocranial, areocaudal as a corresponding to CT images, okay? So this is, see, this is areocranial, skinny appendage, areocaudal when it's a thick appendage. And so it's a 45, 135, areocaudal, areocranial, so that we are speaking the same language. And then you can actually do from this lateral view, you can actually orient the image in areocaudal view, which is the implanting view, areocaudal view, which the device is implanted then. And then even pre-procedural, we know exactly how the fluoroscopy is going to look like. And then essentially, indeed, this is a chicken wing, nicely seen. Okay, and again, this is a third element of doing how you do by CT. Okay, it's all of these angles, standard views, everything 1 to 2 millimeters larger than a TE measurements. So again, and I'm trying to emphasize, you can't do on a TE, you can have 350 images, you can have 60 views. But I really try to emphasize that you use a minimum number of useful views. Minimum number of useful that will provide you. And so at NYU, I developed this NYU 5-clip minimum TE protocol for left atrial appendage. Now, this is it. If you do this, okay, first is a biplane view, 0 and 90 degrees. So you have a 0 and 90, 2 canonical views. But then it's even most important is this one, that the other, if you just had one view of the left atrial appendage would be this, simultaneous biplane view 45, 135. So by the way, you know, I'm active in American Society of Echo, and they strongly discourage us to use X-plane because the proprietary Philips, we have to use it politically correct term, which is a simultaneous biplane view. So you heard it. Okay. Okay, and then we always use a spectral Doppler to see the emptying velocity. And you can actually see why we do. Ironically, we might actually prefer, in some respect, a less contractile appendage than a more contractile appendage. Because it's a very contractile appendage, it might actually lead, increased chance of complication. And then what we do then is we acquire a 3D zoom image of the left atrial appendage. And then we orient it always in the same way. Okay, and we decided this is in our institution, you can choose something else. And we do this with the mitral valve at 5 o'clock, left upper pulmonary vein at 9 o'clock, and pulmonary artery at noon. And then you always know where you are. So when you orient this image, and this is important when you're assessing, for instance, relationship between the device disc and the mitral valve, or the pulmonary vein, which are very important anatomic variant. And then you can change the rendering of the image. Interesting, change the filter, but then this is more important. This is what we want, okay? So we want the 3D shape by left H, by TE. I showed you CT, it's powerful, but we can do this by TE. And we actually just published this technique, how we do this. You can read about it, and then since then we even improved it and made it even simpler. But this is a 3D glass view. Again, I'm showing you this chicken wing. But again, we have to orient it counterclockwise by 90 degrees to become areocaudal view, and you nicely label images, all of that, and this is, in quietly teaching people, without expressly telling them, you just label the image, and then everybody in the room can learn what we are talking about. Okay, and then, again, so this is comparison, and then we are really areocaudal. So again, fluoroscopist, CT, T person is speaking the same language. Okay, and then this is what was done intraprocedurally. So again, we have to know we are going there, but we have to know where we have been. So this is fresh implant, yes? It's a fresh implant. How do we know that it's a fresh implant? Anybody in the room? How do you know that it's a fresh implant? Say it again? Echolucency, absolutely. So this is, exactly, so this we do closed criteria. The reason why I'm mentioning closed criteria is because they were really fluoroscopy driven. Mostly, that is really, as opposed to the other device, which is really sort of pass criteria at the T, very dependent. Here we have a lobe compression and orientation. But it's actually, is exactly that it's very important. There's a 2/3 past the circ, that's fine. But it's more important, this is echolucent. That's a normal finding at the time of implantation. So it's a really normal finding at the time of implant, and this is 3-month follow-up. So this is, it clearly shows that there is now echo-dense inside, and this is the expected endothelialization. I actually like an intra-device clot formation, then I avoided, and I says appropriate tissue ingrowth into the device. If these two images looked exactly the same, meaning if the post-procedural imaging 3 months exactly would look like the implant, that is echolucence, that there is a leak, and it's until proven otherwise. You agree? I mean, it has to be a leak because it's why it's not implanting. And then also, if you look at this, this is again fresh implant because you see that there is a seeping, that it's a beautiful Coke bottle example that you heard earlier. So you can very clearly seeping into the device, and there is no para-device, but there is a clearly flow into the device. And you also see that we are using at a Nyquist limit of 38. So it's very important that all of this, we are talking about the leaks, that we use consistently. It's about 35 to 40 that we use this same Nyquist limit because that encodes more color than the others. And then actually you can see that there is a normal color flow into the device. And then after we place the device, we immediately turn to 3D unfast view and actually see again, we oriented mitral valve at 5 o'clock, left the pulmonary vein somewhere about 9, 10 o'clock. And actually you can see immediately with a single view that the disc is not interfering with the mitral valve, nor is obstructing the left upper pulmonary vein. Okay? And then you can actually see again this very similar. And the reason why I'm showing this is a normal finding of figure 8. Unfortunately, to this day, I get panic calls. NYU is a large institution. We do 100,000 echoes a year. And I get a panic call, something's wrong with the device, and I look at this. So this is a normal finding. It occurs only at the very specific, to have this image, which is complete to all implants, PF4, ASD, or amulet closure, ultrasound has to do exactly perpendicular to the device, exactly perpendicular. If you just rotate the probe a little bit less, actually the figure 8 will disappear. So it's important that it's a normal finding, so not to panic. And also this also could be a normal finding. This is like a letter X finding that actually you can also see it on a CT. This is also a normal finding, not abnormal, okay? And now it's a 90 degrees at the follow-up. So this is good result or not good result? This is 3 months follow-up. So you have inside, there is a tissue organization inside, and also the disc is almost on the top of the left atrial appendage. That decreases the chance of device-associated thrombus at the LA surface of the device. So even if I don't put the color here, I already know that it's really, the leak is very unlikely, and my suspicion for the device-related thrombus is low. Okay, so this free of service, but it's even easier if you look at the 3D, you look at the AMFAS, you see the threaded insert in the middle, and then there is nothing on to tell there is a thrombus. So this, it's a free of clot. And then here, that's clear, that's echo dense. So if you see echo dense on a follow-up, that's a good sign. If you don't see it, look for a leak until proven otherwise. Look the color everywhere with this, okay? So pay attention, you'll be asked questions during that. Is it okay? Okay, so now this is, there is no para-device leak. Okay, again, it's about 35 to 40. So now you'll be asked questions. Is there anybody who wants to volunteer? Want to volunteer? Sure. Okay, good, excellent. So leak or no leak, okay? You see, I'm gonna even point to the arrow. So come 3 months, should we say that it was implanted was not the greatest? And there is something, a flow, There is no leak, So, but it's key that the reason, excellent. So the reason I'm spoiling you see the color, you said it's sort of a tubular flow, but you actually always have to pair it with the spectral Doppler tracing, okay? So spectral Doppler, because it will tell us what the pattern is. So this is spectral Doppler tracing of this, So what do you need? What the spectral Doppler tracing or what? Flow in what? Maybe I can help, Anybody? Circumflex, And this is a left-sided, this is a left-sided coronary. Yes, you know that's left-sided coronary, not the right-sided? Yes? Of course, better be, So the right would be, what would be the right? The right would be systole dominant, as opposed to left-sided is a diastolic dominant, So this is not a leak, this is coronary artery flow. Okay, how about this? Is this, anybody volunteers that I want to pull out, Is this a leak or not? Again, look in color. And it's appropriate Nyquist limit, So, Siddiqui, what do you think?
I would check Doppler.
Excellent, That's good, okay. So now I show you Doppler flow, Now what?
It's a leak.
It's a leak, excellent. Because this is to and fro flow. This is essentially equivalent to pseudoaneurysm flow. So just don't rely on color, just to really be more sophisticated, okay? So to and fro flow. How about this? Who wants to volunteer for this? Leak or not? No leak. What is it? Transverse sinus. I mean, that's important. I mean, just really, these are all second opinions. So, device-related thrombus or not? How about this, So, this is 3 months later. Is this a clot or not? Probably not. Okay, probably not. Okay, that's good. Okay, so, but turn 3D. See, look at this. This is 3D, It's a very clean, threaded insert, nothing. Mitral valve is not obstructing, pulmonary vein is not obstructing, It's always the same orientation, Okay? So, that's an imaging artifact, How about this? Yes. Okay, for several reasons. I mean, you see that the disc is pretty low. Okay, and actually you can see it how disc is, and essentially exactly in that triangle between the Coumadin ridge, Q-tip. Oh, that's the left atrial ridge. That's politically correct. Okay, so but you can clearly see that there is clot. But then you turn on, and then what I called, I have to come up, with words. So this, I call it stuck chewing gum sign, okay? So it's like really, I feel like somebody takes, chewing gum and sticks it on a desk and table, and that's how I look. This is how it has to look like, okay? So chewing style, not bad. English is my second language. Okay, so it's, okay. So this is few more images from CT, and this is a CT image of a patient. So what do you think? It's good occlusion or not? Huh?
There's thrombus in the appendage.
There's,
I get the call.
That's of course, that's expected. That's what I said, that's a tissue. Okay, so this is here clearly there is a difference between opacification of the left atrium and no opacification of the left atrial appendage. That's good, Okay, so this is opacified, and actually even density inside the left atrium. And also if you do 3D CT of this, now you just see only the device. You don't see the rest of the left atrial appendage because there is no contrast, so you can't actually see it. So this is, then I like these two when they are nicely closed and you actually see the device lobe and the disc upside down. So there is no leak. Okay, and how about this? This is CT, unfast view from inside. This is sort of like a 3D zoom view. And again, I want to point out that there is also that letter X artifact that you actually also have to look at that. Okay, so, and but sometimes you have to be all honest. Not all pictures are nice. Sometimes this is it a leak or no leak? Yes. Of course. I mean, it's a malpositioned device, malaligned. And then when you do this, because there is a flow into the appendage, now you can actually see the distal appendage. So it's an easy way to do it. Okay, so the opacified distal appendage. Okay, so I'll close. This is amulet with the para-device leak. This is a pre-amulet left atrial appendage. But this is a perfectly closed, normal amulet appendage, and I hope all appendages look like this. So I hope you enjoy it. Thank you very much.
That was phenomenal. I think we should have more of Dr. Saric in these conferences. In the interest of time, I want to get to the audience question, but please do come up to the mics and go over your questions. So I want to start with Dr. Price. I think, Dr. Price, this was mainly regarding your talk. Do you run into problems with your CT analysis when it comes to pectinate muscles and your landing zone? And how do you assess the middle of the appendage with CT?
Yeah, I mean, I think that's one Achilles heel. If you have very deep pectinate that are rigid, that sometimes it overcalls the depth of the usable depth. But it's really the exception to the rule. And I don't think it really affects things because you would see it by TE. I guess it could occasionally say, well, it's not a feasible appendage to close. But that's really the exception to the rule. So there are times where you get in there and yes, it's not as much depth as you would imagine.
Can I have just a quick teaching point? Am I allowed? Huh? Yeah. So, like we always talk about pectinates. We always talk about pectinates. And I'll give $20 to anybody who can tell me what the word pectinate means, not the people whom I told last night. I have never given $20. Okay? Anybody pectinate? No? It means a comb-like. Comb. Comb, so it's a little, looks like in the 135, you lick all the little, it's a comb-like. So it's important as a community that we know what the words are. Okay?
Incredible. There's a question on rotational angiography and what angles we use and what the advantages are. I'm going to let one of you guys take the whole question on rotational angiography. For me, I just use arteriocaudal and arteriocrani. So any thoughts of?
I know there are some systems, fluorosystems, which can do a rotation, and then you can go back and forth. I don't use rotational angiography, so I can't comment. I think Dr. Siddiqui mentioned that in his presentation. So,
I've seen it in work, but I don't have personal experience. But I would think with amulet it'll work nicely, but I've limited. Anyone in the audience has any experience? Okay.
So we have a question on micro and mini TE probes. We talked about TE regular probes and ICE, and that's a new thing, the micro probes and the mini probes. What are your thoughts on where that is going to affect us in the future of LAAO, and how do you think of the images?
And that is a possibility. I mean, this is essentially another marketing way to market a pediatric probe as a no probe. And essentially, these mini probes are essentially pediatric probe, which are with the 3D capabilities. And it's an interesting, it's these 3D probes, because they are much smaller, might be passing easily, but at the same time, it's also coiling of a small probe in the esophagus is also a higher chance. I think there is clearly a possibility because it's easier to pass it and it's a quicker, and the biggest advantage is that it's has a 3D capabilities. And for us, adult echocardiography is good that the finally company decided to use hand controls that are equivalent to adult TEs. If you ever use pediatric probe, you see that there is a very different, the big wheel is actually angle wheel and the little wheel is equivalent of the big wheel. So there is a future with that, particularly because it's 3D.
This question is mainly, I'm going to give it to you, Christoph. It's a comment on what the maximum diameter on the TE and the perimeter-derived diameter on CT, and how do you decide the landing zone? I know we have a talk coming up later on appropriate sizing, but just your thoughts on that.
So maybe I go back 2 steps because I can give you a European perspective on sizing, and we do all sizing with TEE. So the first very important aspect if we talk about imaging is that we must have proper pre-planning to optimize results and outcomes, and then you can streamline the procedure and use maybe just 2D eyes during the procedure. But I would not mix up too much imaging modalities and compare 3D imaging from echo with 3D imaging from CT scans. But what I can tell you is that if you use 3D imaging based on TEE, you will have proper sizing as well, and you just have to accommodate your strategies, how to choose your device size based on your measurements. And I think the most important aspect is that you have a proper three-dimensional multiplanar reconstruction of your landing zone, and then keep in mind the oval shape of the appendage, which sometimes can be very extreme. And if you have a minimum and a maximum diameter, and you have a really a very oval shape of the landing zone, you should always not too oversize the device because you have much compression. And in this situation, yes, it could be helpful that you make your sizing based on the mean diameter, which keeps all diameters, I would say, in mind.
So we have a question on, we're talking about procedural efficiencies and cutting back on things, and there's a question about if you have a pre-CT and you have an intraprocedural angio, do we even need TE or 3D eyes? So, and does it affect PDL rates? So I'm going to take the answer, and then I will have all of you step in because I'm pretty opinionated about it. I believe that for an amulet implant, you have to have imaging other than fluoroscopy because your close, your C is your lobe past 2/3 past the circumflex, which maybe as an EP, I just haven't figured out how to see a circumflex that's not stented on the fluoroscopy. So you have to be able to see that your lobe is 2/3 past the circ. And that is the number one, indication for release. So for me, I would say you have to have imaging. Yeah, we'll go this way.
Yeah, I agree with you completely. I mean, if given 3 options, pre-CT, intraprocedure, angio, and the TE, I would maybe take CT out and use the intraprocedure, angio, and TE. Now, if your CT is really, really good quality, and you have it well established, like the way Dr. Price mentioned, and your success rate of device opening gets translated to the same device usage, then I would probably take the intraprocedure angio out. But ICE or TE is extremely important to understand that once the ball forms, you got to go past the circ. And that sometimes is really difficult in an angio. I'll give you a quick example of a case we did where on angio the size came out to be 28 millimeters, but when you look at the TE and ICE, there was a prominent pectinate muscle, and the actual device that could fit was only a 22. So sometimes it could be deceiving which angle you do on the angio.
So the same, for me, you need absolutely interprocedural imaging with echo, and I use fluoroscopy only to have an, I would say, impression of the orientation of the appendage, but not for sizing. This is the reason why I completely skipped angios of the appendage to completely omit contrast. So I give, this is maybe just an extreme, but you can do it without angiograms, but fluoroscopy to have I would say, an idea how the orientation of the appendages in the left atrium.
Yeah, just 3 quick things. I think if you go angio alone, you will miss sometimes in some quadrants where you are relative to the circ. I think occasionally, I think CT works really well. Sometimes even the TE into procedure is not right because of pectinates. I like to say you need to let the LAA speak to you. You're not speaking to the appendage, so sometimes you have to switch it out because that will be the thing. And in terms of, I just think we need to eliminate people from the cath lab or the EP lab. We have a saying that collaboration means doing things on other people's schedules. So if you can eliminate as much collaboration as possible, and have a sonographer there and ICE, and get a CT beforehand, I think you'll be happy.
Matt, there was a question for you while you have the microphone. What, in your experience, what frequency of CT pre-screens co-register with the TE on the table?
Well, if I'm going to do TE on the table, I'm not going to do ICE because that's just a waste of money and resources. But we've done studies. The sizing works really well. I don't do baseline sizing based on ICE. I think that's challenging. I think Dr. Siddiqui mentioned that because you're not going to get perfect angles to make sure that you get the maximum diameter. You can do 3D NPR with ICE and get the maximum diameter. It can be done. Yeah.
CT correlation to TE.
Oh, CT correlation to CT.
So you open a device, does it correlate with TE and parameters? How does that correlation work?
I would say
don't
they're
really
usually
understand.
about a few millimeters off.
Yeah.
Oh, yeah, so the T is
CT
gonna be a little
is
bit
usually
smaller.
a
1 to 2
little bit
millimeter large,
bigger.
Yeah.
Yeah.
T is going to be a little bit smaller.
Yeah. So when I just comment, I mean, with respect to T versus CT interprocedurally, I can tell we have done procedures with interprocedural T only, no fluoroscopy, but I have never participated in reverse. So that's, but they're asking 2 questions. Okay, so I had the 2 questions, 3D versus 4D ICE. That's really, it's an important question. So it depending where you come from, whether you come from the echo world or you come from CT world. So in echo, historically, we always had the time as a one dimension that it's assumed. So in echo, when we talk about the dimensions, we talk about the spatial dimensions. So we had the 1D M mode, that we had the 2D spatial, and then we had the 3D spatial. And we always assume that the time is there. So essentially 3D spatial plus time. As opposed if you come like a GE from CT, CT intrinsically was always 3D spatial. And then, but historically, moving imaging was not part of that. And now, when from their perspective, if you add time to it, all of a sudden now it becomes a 4D. But from the spatial concept, is they're the same. So it's a 3D, both are the same. And the other is whether we can, esophageal varices, whether you can do TE. If you look at the ASC guidelines on TE, varices are relative contraindication. And that really depends the size of the varices, because you know that's anastomosis between a portal and systemic circulation at the GE junction. They could be only at the GE junction, but could be very, very high. So it's first you have to know how much. But luckily for the left atrial appendage, we don't need transgastric views. We just need a mid-esophageal view and a relatively high mid-esophageal view. So staying away from the GE junction, not going deep, is actually acceptable in most instances. Should I? Huh? And now I'm being told that we ran out of time. The lunches we are standing in front of and preventing you from lunch. So I hope you enjoyed the session, and lunch is out.
There was a comment on whether we should use chewed gum for leak closure. I think we should just avoid leaks.